Good afternoon. Thank you for giving me the opportunity to present my research. My name is Jennifer Noble. I'll be presenting how patient and provider factors influence chest radiography use in the diagnosis of pediatric pneumonia. My colleagues and I have no financial or commercial interests to disclose. In 2011, the IDSA published guidelines for the management of community-acquired pneumonia for infants greater than 3 months in children. This was endorsed in 2012 by the American Academy of Pediatrics. A small section addressed the management of outpatient pneumonia, recommending against the use of chest radiography and laboratory studies, with amoxicillin as the antibiotic of choice. Evidence showed that chest X-ray had no substantial impact on clinical outcomes for the management of outpatient pneumonia. Subsequent literature has demonstrated that the guideline adaptation had minimal impact on the total chest X-ray use in diagnosing community-acquired pneumonia in an emergency department. What is not known, however, is how patient or provider characteristics influence chest X-ray usage. Our goal was to determine what patient and provider factors affect chest X-ray usage at a tertiary pediatric emergency department. This is a retrospective analysis of children discharged from a single level 1 urban academic emergency department with the diagnosis of a community-acquired pneumonia. Community-acquired pneumonia was defined by ICD-9 and 10 guidelines. We included all children 3 months to 18 years with the diagnosis of community-acquired pneumonia who presented to the emergency department and were discharged. Data was obtained by chart review, including chest X-ray usage, type of provider, as there are multiple provider levels within our emergency department, and patient characteristics. We compared chest X-ray usage from 2010 to 2012 pre-guideline with 2013 to 2017 post-guideline using descriptive statistics, chi-squared, and multivariate logistic regression. There were over 6,000 patients included in this study. Over 2,000 were in the pre-category and almost 4,000 were in the post-category. As you'll see, almost half of them were female, over 67% were African American, and over 78% were on Medicaid. The age distribution demonstrates that most children were under the age of 12 years. There was no difference in chest X-ray usage in the post period. What we did find is that care by advanced practice providers increased chest X-ray usage. So factors associated with reduced chest X-ray usage included a history of pneumonia, history of developmental delay, and being seen by a pediatrician. Factors associated with an increase in chest X-ray usage include if they were seen by an advanced practice provider, if they received testing such as flu, strep, or blood tests, and if they presented with an increased respiratory rate or increased work of breathing on exam. There was no association found for gender, age, Medicaid, season of presentation, RSV testing, or history of asthma. On adjusted analysis, several factors were independently associated with less chest X-ray usage, but this was balanced by factors favoring chest X-ray, leaving overall use unchanged in the post period. The limitations of this study are that it's a single center retrospective study, hence results may not be generalizable to other institutions. Further explorations of the complex interaction between patient and provider characteristics on the decision to obtain chest X-ray is needed to improve guideline compliance. Implementing low-cost strategies could also help improve guideline compliance, and investigating if lung point-of-care ultrasound could be used for the detection of pneumonia would it also improve guideline compliance. I would like to acknowledge my faculty mentor, Dr. Ehrman, as well as several research assistants that assisted with the data analysis. Attached are my references. Thank you again for your attention, and please email me with questions. Thank you.